Error at the end of my last video. We're actually doing 4 and 5 in one section here of Brightspace. So first part of this, the selected synovial joints will be part of the videos for the same as the last video. But if you're looking at this, you've already figured that out, so I'll stop rambling and get going on some specific synovial joints we need to look at. The synovial joints are quite diverse. They all have some same general features, but many have unique structural features, abilities, and weaknesses in particular. There are 5 main that we'll look at. The jaw, which is the temporomandibular joint, the shoulder, the elbow, the hip, and the knee. So if we start with the temporomandibular joint, which is TMJ, we'll get to that initials in a moment. The joint is a modified hinge joint. The mandible condyle articulates with the temporal bone. Posterior temporal bone forms a mandibular fossa, while the anterior forms the articular tubercle, and the articular capsule thickens into the strong lateral ligament. There are 2 types of movements allowed here: hinge, which is depression and elevation of the mandible, and a gliding, a side to side lateral excursion that when we grind our teeth. Now this joint is the most easily dislocated joint in the body. And if someone has been diagnosed with TMJ, there's a problem with this temporomandibular joint. We all have a temporomandibular joint. Some have problems with it. We see it here. And here is our side-to-side movements. And up and down. So here, dislocation of the TMJ is the most common dislocation because of the shallow socket of the joint. It almost always dislocates anteriorly, causing the mouth to remain open, and then to realign it, the physician must push the mandible back into place. Symptoms would include ear and face pain, tender muscles, popping sounds when you open the mouth, and joint stiffness, usually caused by grinding the teeth, but it can also be due to jaw trauma or poor occlusion of the teeth. So treatment might be to provide a bite plate, especially when you're sleeping, and learning to relax your jaw muscles can help as well. So the shoulder joint is the most freely moving joint in the body. Stability has been sacrificed for freedom of movement. It's a ball and socket joint, much like the hip, but the large hemispherical head of the humerus fits in a very small, shallow glenoid cavity of the scapula, more like a golf ball on a tee than being encased in that capsule. The articulate capsule enclosing the cavity is also thin and loose, and that contributes to the freedom of movement. The glenoid labrum is a fibrocartilaginous rim that is around the glenoid cavity. That helps to add some depth to the shallow cavity, but it still only holds about 1/3 of the head of the humerus. There are reinforcing ligaments, mostly on the anterior or front aspects, including the coracohumeral ligament, which helps support the weight of the upper limb. The glenohumeral ligaments, which strengthen the anterior capsule but provide very little support. And there are reinforcing muscles and tendons that contribute to the joint stability. The tendon on the long head of the biceps brachii muscle is the superstabilizer. It goes through the intratubercular sulcus and secures the humerus to the glenoid cavity. There are also 4 rotator cuff tendons that encircle the shoulder joint: the subscapularis, the supraspinatus, the infraspinatus, and the teres minor. Shoulder dislocations are common injuries due to the mobility of the shoulder. Structures reinforcing that joint are the weakest anteriorly and inferiorly, so the head of the humerus can easily be dislocated forward and downward. The glenoid cavity provides poor support when the humerus is rotated laterally and abducted, so when a football player uses his arm to tackle an opponent, and blows to the top and back of the shoulder can also cause dislocations. Alright, let's get this video playing. I believe.
All four muscles combine at the humeral head by way of tendons and form a cuff over the joint, hence the name rotator cuff.
Okay. Don't know what the audio issue is here. Let me try unplugging that.
There are 9 muscles that cross the shoulder joint and act on the humerus. Of these 9 muscles, only 3, the latissimus dorsi, the pectoralis major, and the deltoid muscles are considered prime movers of the shoulder joint. The other 6 muscles play a synergistic role in movement, but their primary role is to stabilize the shoulder joint. 4 of these, the supraspinatus, infraspinatus, teres minor, and the subscapularis, are grouped as the rotator cuff muscles and are discussed separately. The remaining 2 muscles are the teres major and the coracobrachialis. The muscle origins and insertions in relation to the glenohumeral joint are best introduced as anterior and posterior muscles that originate off of the scapula, and anterior and posterior muscles that originate off the axial skeleton.
Okay. Here we go. I hope. Nope, we got an audio.
The anterior scapular muscles that cross the glenohumeral joint are the coracobrachialis, the biceps brachii, and the deltoid. The coracobrachialis muscle originates on the coracoid process of the scapula and inserts on the medial surface of the humeral shaft. The biceps brachii muscle has 2 parts, a long head and a short head. The short head originates on the coracoid process of the scapula, while the long head originates on the supraglenoid tubercle of the glenoid cavity. The 2 heads of the biceps come together distally and insert on the radial tuberosity, just distal to the elbow joint. The deltoid muscle is composed of 3 distinct sets of fibers: the anterior fibers, which originate from the anterior border and lateral third of the clavicle, the middle fibers, which originate on the lateral margin and acromion of the scapula, and the posterior fibers, which originate on the posterior border of the spine of the scapula. All fibers converge to insert at the deltoid tuberosity of the humerus.
Okay. One more. At least. You notice we're talking a lot about muscles because muscles are also a part of joints, although we will be covering the muscles in the next chapter.
The posterior scapular muscle that crosses the glenohumeral joint is the teres major muscle. The teres major muscle originates on the inferior angle of the scapula and inserts on the medial edge of the intertubercular sulcus of the humerus.
Okay. The elbow joint. The humerus is going to articulate with the radius and the ulna. It's a hinge joint formed primarily from the trochlear notch of the ulna, articulating with the trochlear of the humerus. This is going to allow for flexion and extension only. It's a hinge joint. The annular ligament is going to surround the head of the radius, and there are two capsular ligaments that are going to restrict side-to-side movement, the ulna collateral ligament and the radial collateral ligament. And let's get this one going. The other good thing about these videos is you get to hear someone else's pronunciation of some of these terms and muscles when the audio works. Whoops. Come on. Almost there. Fix the audio.
The forearm flexors consist of the brachialis, the brachioradialis, and the biceps brachii. The brachialis muscle originates on the front distal half of the humerus and inserts on the coronoid process of the ulna. The brachioradialis originates on the lateral supracondylar ridge of the humerus and inserts on the base of the styloid process of the radius. The biceps brachii has two parts, a long head and a short head. The short head originates on the coracoid process of the scapula, while the long head originates on the supraglenoid tubercle of the scapula. The two heads of the biceps come together distally to insert on the radial tuberosity, just distal to the elbow joint.
Okay. So the elbow joint here. Here, and a dissected version, and a rotating version. Oop. Can I go back? Nope. All right, let's take a look at the elbow joint.
The elbow joint is a hinge joint. Therefore, the muscles that act on this joint are limited to flexion and extension of the forearm at the humero-ulnar joint, while the forearm itself is capable of pronation and supination.
Down to, whoops, sorry. Here we go. Down to the hip, we have or coxal joint. With, again, we have a ball and socket, but there's a large spherical head on the femur that articulates deep into the cup-shaped acetabulum, which still gives us a good range of motion, but limited, especially compared to the shoulder, which is the same type of ball and socket joint. So the acetabular labrum is a rim of fibrocartilage that enhances the depth of the socket. Hip dislocations are quite rare. So again, you can see, oh, my pointer's gone, but the head of that femur fits pretty deep into the joint itself. So let's take a quick look at some movements allowed at the hip joint.
The two principal anterior muscles. The two principal anterior muscles of the hip are the iliacus and the psoas major. Collectively, they are known as the iliopsoas muscle because they share a common insertion on the lesser trochanter of the femur. The iliacus muscle originates on the iliac crest and fossa of the pelvis. The psoas major muscle originates on the bodies of vertebrae T12 through L5 and the transverse processes of all lumbar vertebrae.
Okay, dissected hip joint. The reinforcing ligaments here, the iliofemoral ligament, the pubofemoral ligament, the ischiofemoral ligament, and the ligament of the head of the femur, also called the ligamentum teres. These are slack during most hip movements, so not important in stabilizing this ligament of the head, but it does contain an artery that supplies blood to the head of the femur. Most of the stability comes from the depth of the ball and socket joint. The knee joint, we have the largest and most complex joint of the body. It's actually 3 joints surrounded by a single cavity. There is a femoropatellar joint, which is a plane joint, allows gliding motion during the knee flexion. Lateral joint and medial joint. The lateral and medial joints together are called the tibiofemoral joint. They're joints between the femoral condyles and the lateral and medial menisci of the tibia. This is a hinge joint that allows for flexion, extension, and some rotation if the knee is partly flexed. All right, let's take a look at the knee.
Muscles that act on the knee joint.
Why does it do that?
Muscles that act on the knee joint form most of the mass of the thigh and are located both anteriorly and posteriorly.
So the joint capsule is thin and absent in the front anteriorly. Anteriorly, the quadriceps tendon is going to give rise to 3 broad ligaments that run from the patella to the tibia. They're the medial and lateral patella reticulata. They're going to flank to be on the sides of the patellar ligament. That's where the doctor will tap his rubber mallet to test the knee jerk reaction. There are at least 12 bursa associated with the knee. There are capsular, extracapsular, or intracapsular ligaments that act to stabilize the knee joint. Capsular and extracapsular ligaments help prevent extension of the knee. So we've got fibular and tibial collateral ligaments. That's going to prevent rotation when the knee is extended. The oblique popliteal ligament stabilizes the posterior knee joint, while the accurate popliteal ligament reinforces the capsule posteriorly. The intracapsular ligaments reside within the capsule, but they are outside the synovial cavity itself. They're going to help prevent anterior-posterior displacement. We have the ACL, the anterior cruciate ligament, attaching to the anterior tibia, preventing forward sliding of the tibia and stopping hyperextension of the knee. And the posterior cruciate ligament, which attaches to the posterior tibia and prevents the backward sliding of the tibia and forward sliding of the femur. The knee absorbs a great amount of vertical force, but it is very vulnerable to horizontal blows. So some common knee injuries involve 3 C's: collateral ligaments, cruciate ligaments, and cartilages, which would be the menisces, but menisces doesn't start with C. So lateral blows extend the knee can result in tears in the tibial collateral ligament, medial meniscus, and the anterior cruciate ligament. Injuries affecting just the ACL are common in runners, especially those that change directions quickly, and that will involve twisting of the ACL. Surgery is usually needed to repair these. They don't repair well on their own. So here is a hockey puck hitting the side of some hockey player's knee. You get the tear of the tibial collateral ligament, the medial meniscus, and the anterior cruciate ligament. All right, now that concludes section 5, and that is where I'm going to stop this time. So you'll notice that 4 and 5 are the bulk of everything we've talked about. And that's where the bulk of your homework questions are coming from. Now we have just one more section.